Start a good evening to everyone. Hope everyone is doing well. Welcome to week 5, you all. It is, we really are halfway through. Um, and I say that because, we had it 12 weeks, but, week 12 was we just meet just to go over some preliminary stuff and look at your test results and we meet for attendance. Then week 11 is HESI. So it's week 5. So really we are halfway through. So as I do a little rambling here, make sure you put your name and campus in the chat. We're finding that some of you are not placing your name and campus in the chat. Make sure you're doing that. They check, it's just a check of a check. So make sure your screen name is correct. So when they look and see that you put your name and campus in the chat. They see that your screen name match your name and campus is in the chat. Y'all, there's a reason for all of that. And they're asking you to do that. So make sure that you do that before leaving class tonight. Just get in the habit of doing it when you log in. Because you don't want them to say, well, hey, you marked this student present and they really weren't there. When in fact you really were here. So just make sure you do that. And so with your schedules, like I said, we really are halfway. Start looking at those things. Usually after that first exam anyway, things just go by really fast. Make sure that you're looking at, what's really required. Start making those adjustments and those things that you really don't have to do and you need that time to put towards studying or reviewing things. Put those things on pause. You don't always come back to those things, because nursing school doesn't last forever, even though I know sometimes it probably feels like that. But you're almost like right here at the halfway toward the end. So just be looking at those things that you can adjust, rearrange, put on pause, and delete those things that you surely can delete. So they are, and they really don't want the uh, poster boards, handouts, but since our exam is next week, we're just gonna be thinking in that frame. So we got to narrow it down. For poster boards, just think about when you walk, or even when you're looking on the social media sites, there's limited space. So people have to be really thoughtful about what they actually select to put on the space. They have to think about the colors and all of that. So we're going to kind of play like we are going to design some handouts or some postings that we're going to put on social media site about mental health. And so I want you to be just thinking of that, even though we're not going to really create these things, but it's so that you can quickly identify those things, those terms and concepts that you're going to need to go back and make sure you spend more time with, because not as don't have a strong foundational understanding of them. And then for those that you are, you can put those terms or concepts at the bottom of your list. For sure, you're going to review all of it, because that's what you're just going to do until the end anyways. Until you take that NCLEX, you should be just reviewing all of your content. But I just want us to kind of think of it that way as we go through class tonight, so that you can quickly identify those things, those concepts that you're going to need to spend more time with between here and next week, before we take that exam. All right. So good evening to everyone. Hopefully everyone is doing well. Welcome to week 5 again. Go ahead and place your name and campus in the chat. I think Dr. Bugs will do a exam review next week. Not really sure, but whatever she decides to do, you will be informed. It will be placed in the announcement section. So just be looking out for that. And so how next week will go, we'll come in and we'll do some review. No new content. Tonight we'll go back and grab last week's content and this week's content. So we will be talking a lot, just making sure that you're asking your questions if something is not sitting well with you. And then also just make note of those things that you're like, what? They're talking about obsessive compulsive disorder. I have no idea what that is. So let me put this at the top of my list. So that would be, so create your list of things that you need to start with looking at first, second, and the third. So we will come in, we'll do our review, and then we'll take the exam at the latter part of class. So that's how it will actually go. Now, not sure, I haven't heard from anyone saying they're thinking about getting that exam proctored on campus, but be mindful of what that process entails. Your campus dean has to approve whomever your faculty campus proctor is going to be. And also you have to give that 72-hour notice. First of all, your campus has to approve for it to even take place. Some campuses do and some don't. So that's a conversation that you would need to have with your campus dean, and then whomever that person is that they select or identify to proctor that exam. All of that needs to be put in an email so that we can prepare your exam for you. Okay, let me pull up our modules here so we can see where we're going. So then after next week, just like you all did, I think you all were in what, P's first? So you'll transition. So next week will be week 6. So 7, 8, and 9, you will spend with your last professor for whatever that class is. Whichever class you have not taken as part of this 3-section class. All right, let me get it down here. How is the weather where you all are at? Any storms brewing or everything is settled? No smog? Everything's okay? Okay, so this was last week. So of course we're going to go back and capture that information too. It's going to pull it all together. And then we look at this content here: violence, suicide, substance related disorders. And then we go ahead and capture the psychotherapeutic drug therapy as well. So next week it'll be just a review for everything and the exam. All right. You all are a quiet class. I, are you all hearing me? Because I asked about the weather. I didn't hear a response from anybody. Can you all hear me? Just making sure you can't hear.
We hear you just fine. We just all got our mics on mute.
Okay, okay. I'll just make it sure. Okay. All right. Here we go. Let's get ready to look at this content. And again, you have this information, you all. I kind of just put it all together as one PowerPoint today. So it's like, wow, that's a humongous PowerPoint. And then another thing that I did, I tried to add in designs because it's just a thing I do. Um, and so, when you download those PowerPoints, you can go and add whatever and make them your own. You can actually turn them into notes. You can add like a note part to it. I don't know if you really thought about it, and it might be too time consuming for you, but I tried to do the add some color to it, but then it's like kind of all over the place. But nevertheless, we're looking at it for the content anyway. All right, so here we go. So another way, and we mentioned that before, is looking at your objectives for at the beginning of all the chapters. And that's just for any class. You can look and see if you are able to answer the objectives or to give some response to the objectives, because that pretty much kind of tells you too whether or not which concepts you are familiar with and which ones you're not. So I'm going to call on, I'm going to read some of the slides. I'm going to ask you to read. I'm going to ask you to respond via chat. I don't think I'm going to use my wheel because I want to make sure that we go through all of the content. So if someone would start us off with this slide right here, just kind of just read us through it.
Outward focused emotions, violence. Human beings engage in aggressive or violent behaviors for a variety of reasons. Human reactions can be placed on continuum ranging from calm to violent. So that could be calm, anxiety, agitation, aggression, and abuse and violence.
Okay. So just taking tips, something that comes to mind because this is on a continuum, because people's responses are going to be different depending on which part of this continuum that they're on. We're going to respond a little bit different if we're a little anxious than if we are aggressive. we will still respond differently if we're anxious versus being agitated. So make sure when you're taking the exam, read the question for clarity, which pick out the concept that they're talking about. If they're saying agitation and not violence, the answer choices, the responses will be different. So just make sure that you respond based on what they're actually asking you about. Yeah, so we do have that continuum. Uh-oh, this slide got mixed up here. I don't think it was just showing anything. Let me stop sharing. See, I told y'all I was trying to be fancy. And that slide, I don't know what that was. Oh, see what happened. Let me share it. The little picture, and I added pictures and stuff to mine too. It just landed on top of the words. How does violence influence the members of society? How about we think, how does violence influence the members of society? Some people, did you think that it doesn't influence them at all? Some, it may make them more vigilant towards identifying resources to lessen the violence, so that, and that could be whether making sure like they're advocating for healthcare providers. Like there's a shortage of all different kind of healthcare providers now, from mental health, from endocrinologists, healthcare providers. It's like what? But it's like it's so many people on earth, and because with the advances, because nurses are providing the best care for those clients, they are being proactive in beginning discharge discharge on admission, and just kind of thinking through stuff, being proactive. People are living longer now. So it's like the people are outnumbering the healthcare providers. And so how does violence influence the members of society? It influences them it's a continuum. Some people are trying to identify resources, create resources. They are on social media. You see now where they're making sure, when it's like every month there's a whole list of different health things that they want to bring to people's awareness. And you see posting on that, people are sharing those things. Even they're creating conferences. And so it affects the society differently. But I think overall we're pushing for access and just making things available for people. And they're even starting in, I know like in some school systems, they're even employing, is it social workers? They're employing like that whole team, like social worker, case managers, mental health workers. And that's just an addition to the school day. That's just an additional resource that is actually there. Okay, so social factors and violence. No one is certain exactly why violence occurs. Nurses and other healthcare providers accept the care for all people, but this philosophy is associated with risk for violence. Aggressive and violent acts are committed by members of every group in society. So so we're trying to figure out what in the world can we do? What can we do? And I want to say, was it 2 years ago? And you all may have talked about this, where they have placed bills out there to prosecute, or at least hold people accountable. I would say it like that: hold people accountable that for acts of violence against nurses, because we're there for everybody, no matter what your pay status is, your insurance status is, no matter what your ethnic group is. We're just trying to provide the best care for everybody. Sometimes, and we're there with the people all the time, comparing to like the healthcare provider, compare like the physical therapists, like those people go and come, but the nurses there all the time. So who are we seeing acts of violence being done against? The nurse. And so that is something that you have to be aware of, to your surroundings. If our patients are hallucinating, if they have that altered mental status, we have to be aware that it may have to call upon our team members, because some violence may be intentional and some may be unintentional, but we do see acts of violence against nurses. So separation anxiety disorder. Someone read this for me.
Separation anxiety.
Away from attachment figures common in children, adolescents.
Okay, so this is Look at this word right here. Put it into context. It says excessive. You know, as for example, you almost, I don't know where you're at in your trajectory of finishing, your nursing school, but I know those the students that, my students from yesterday, they're right there at the end. They're taking their final courses. So they're a little, worried or anxious about, hey, we're almost here, finished up the whole nursing program. But this right here is different. They tell us that the weather is kind of like the other night, a couple of weeks back. I think it was this class. I could hear, it was storming outside. I could see the lightning flashing and everything, and hearing the thunder, getting a little, anxious. Like, hey, y'all, I may have to keep on as long as I can. That's just a little worry. But when we talk about excessive worrying, from the attachment from something, it could be from a person, a figure, or something, then this is considered as separation anxiety disorder. It's that excessive worrying about being away from. Okay. It's not just the normal run of a mill anxiety that we'll have in those examples like that I gave. Okay, so OCD involves intrusive thoughts, obsessions, and repetitive behaviors, compulsions to reduce anxiety. So OCD, we're saying, is a person also has anxiety, and they think about certain things, and they actually act out and they do certain things to calm that anxiety. And then it's obsessive and it's compulsive. They just keep on, and it's a repetitive behavior. Okay. So PTSD follows exposure to a traumatic event, and is whatever that person deems as being traumatic, with symptoms including nightmares, flashback, avoidance, and even hypervigilance. So it's so important when we're doing our assessment with our patients that we're, actually asking those questions. Hey, have you ever had a traumatic event? And if you do, to share the information if they like. And people always ask the question. We were given a survey, and the word wasn't traumatic. It was another word, but it actually meant traumatic. And people always ask the question, what they consider, they were always give an example. Is that considered traumatic? Well, if you think it's traumatic, it is, because it's whatever, how you feel in that moment. And the thing about this post-traumatic, it is you're having flashbacks. You think back about what actually happened at that moment in time. And then sometimes it actually prevents the person from moving forward and taking care of themselves and doing those acts of daily living. Okay. So now we have generalized anxiety disorder, also known as GAD. That's chronic excessive worrying over multiple domains, often with physical symptoms like fatigue and irritability. So not only this person has excessive worrying, they also, the stomach may hurt. They may have they may think they have a stomach virus because they're having episodes of diarrhea. They may feel nauseous. They may be throwing up. And so this is excessive worrying in addition to they're having symptoms, but this is generalized anxiety disorder. Okay. First rule out of medical causes for acute symptoms. So what we have to do is, if they send someone in or someone comes to the emergency room, we need to rule out that there's a medical cause. Because, and I know pretty much some of you all work in the healthcare facilities. You have rotated through different rotations with your clinicals, and so you've seen diagnosis. For example, a person may have pneumonia, but then when you look at their chart, like, what? The signs and symptoms, they were doing this, they were experiencing this, and it ended up that they had pneumonia. Urinary tract infection is another one. The patient was doing what? They have like all these different things. It's like almost, especially with the elderly, if they have a urinary tract infection or some type of infection like pneumonia, it's like they turn to a whole different person. Like their mental status totally changes. They may be oriented times four. Then if they have this infection, they may not know where they are. They may not know who they are. And so that's why they said we want to rule out the medical cause. So they'll do like a slate of tests, usually a UA, and they usually do like a comprehensive medical metabolic profile. That's all your hemoglobin, your white blood cells, red blood cells. They'll look at all of those basic labs, magnesium, potassium, BUN, and creatinine, just to make sure that is nothing medical going on with this person. For example, if their kidneys are not functioning properly, so they'll look at the BUN and correct. Well, all those numbers are fine. If the white count is good, then they move on and say, "Hey, yeah, we may be looking at a mental health issue." Then the next thing we want to do is reduce the environmental stimuli. We want to make sure that the temperature of the room is suitable for the person. We may even have to dim the lights. We may have to brighten the lights, but we want to look at that environment. Then therapeutic presence and reassurance help the patients feel safe. We want to, establish those therapeutic relationships early on. We're not, making up stuff. We're not going to, break the rules or anything, but we do want to provide that reality orientation for them. Excuse me, for them. We may want to ask them to do deep breathing exercises and also just other types of exercise and like Tai Chi and things like that. But just usually sitting, taking that deep breath, it refocuses the person some. But first, we want to rule out, make sure nothing medical is going on with the person. And then we move on to environmental and then mental health issues. So, manic episode, when we talk about grandiose delusions, this is grand. So it's the delusions are, I can think of a better word. They're huge. They're big. That's why they say grandiose. So such as a person believing they have special powers, or a special relationship with God. And we're not talking about God as their savior or anything like that. We're saying that they sitting right up there with God and they are creating, lakes and ponds, and they're telling when it's time to be night and day. It's that type of relationship that they think that they have. And this is coming during those manic episodes when someone has bipolar. Okay. Major depressive disorder includes sleep disturbances. They may have insomnia, can't fall asleep, but then they have this excessive sleeping, feeling worthlessness or guilt, and loss of interest or pleasure in activities. So when we're doing that assessment, I ask, what things do you do for leisure? You watch TV, read books, tend to your grandchildren, whatever it is. So see if they have any activities that they do for just pleasure. Delusions of grandeur are characteristics of manic episodes in bipolar disorder. That's what we just said. So that grandeur is more than just, hey, I believe in Jesus. I believe he's my personal savior. It's beyond that. It's like, Jesus has allowed me to divide that mountain that's right there. It's grand. Okay. All right. Someone read this one right here.
Progressive muscle relaxation is particularly effective in managing the physical symptoms of anxiety, such as muscle tension.
Okay, so again, a deep breathing exercise, and then we add in this muscle relaxation. So it can fall under exercise, but nevertheless, it's something that's going to make them relax or allow them to relax. Not anything like running, jumping, hopping. Some of those, I think I'm saying it correctly. Tai Chi, those are those things where you have that more like yoga, where you sit, you meditate, you listen to the different frequencies, but something so that those muscles can relax. Because with anxiety, everything is just tensed up. It's tense. Okay, regular exercise is an effective non-pharmacological intervention for managing anxiety. It helps reduce stress, improve mood, and promote better sleep. So we do have our medications, but think about those non-pharmacologic interventions that we can implement as well. Patients should be educated that they need to continue their medication as prescribed, even when feeling better, to prevent that relapse. And this is with our mental health meds and all of our meds. Because what happens, we may have that cold, or not necessarily a cold, but we may have, I don't know, migraines or what have you, but the doctor orders medicine. Within about 2 days, we should start feeling better. But the thing is, studies have shown that person needs to complete that regimen. And if they're experiencing side effects, we want to encourage them to report those, because adjustments might need to be made. But patients should be told, educated, reinforced Make sure that they understand, you need to take these medicines even though you're feeling better, even though you're not having insomnia, you're not having hyperinsomnia, you are able to complete your activities of daily living. I feel like I'm back in the swing of things. That's good. That's what we want you to. That's what we should be seeing. But don't stop taking your medicines, because as we'll talk about here in a few minutes, not really in a few minutes, but as we talk about here tonight, some medicines they have to make sure that they come back in and get their blood drawn, because they have to be at a certain level and it's considered therapeutic. And usually, if it's at that therapeutic level, for sure, people are feeling better and they're able to live and move on as productive in their lives. So, severe depression can lead to significant changes in appetite and eating habits, potentially resulting in malnutrition. So, who on the healthcare team might we have to bring in to assist us with this? With someone that has severe depression.
Dietitian.
Exactly. Because remember, they're the ones that look at the height, the weight, they calculate that body mass index, and they say, hey, whether or not we're overweight, underweight, or we're right on point. And then they look at the calorie intake, they look at, they'll do like a diet journal, and they'll just write down what people say they ate for certain meals, and they'll look at everything and make sure that it's nice and balanced, and then they'll make those recommendations. So yes, we may have to pull in that dietitian. So during manic episodes, individuals with bipolar disorder may engage in impulsive and excessive spending, because remember, they're hyper at this point. They're experiencing manic episodes within that bipolar. And so everything is like go, 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 go. They just like everything is just fast and hyper. And so they may spend all their money. They may eat, if they're in the spirit of sharing things or giving things away, they may come back and realize they've given their car away because it's excessive. But for sure, they may end up spending all their money, and then it can lead to financial difficulties. If they're giving away their car, that could lead to not only financial, but being able to provide for their families. They may experience a bunch of difficulties. So it's very important that we educate our patients on the disease process, ensure that they have an understanding of what's going on, and also have alternative treatments so they can decide, because they do have preferences. And it's them that's receiving the care. But in the bigger picture of things, we do want them to be productive citizens. So we want to make them aware of everything, the alternatives, pharmacologic, non-pharmacologic, so that they can be well balanced. And so they will not lead to them spending all their money and like giving away their vehicles and things like that. And they don't have, after they come back through the manic episode, then they don't have transportation or funds to replace what they've given away. Positive coping strategies. So we have positive and we have maladaptive. So for positive coping strategies, this person is able to manage that stress constructively or well. Their emotions are in check or they're regulated, and they just have it, whatever strategies that they've come up with that works for them. And there's a number of strategies here, is allowing them to be that productive citizen. They're taking care of themselves. They're able to bathe themselves, keep themselves fed. If they have family members that rely upon them, they're taking care of them. They're going to work. They're not missing days. And so positive coping strategies help the person maintain and keep things in check. And then this is not an exhaustive list, but these are some things that they have that we consider as positive coping strategies. Yoga, spiritual resources, music therapy. I think we'll talk more about that, the version. I think I have a slide on that. Massage, meditation, there's a number of things. But nevertheless, they're positive, and it helps that person continues to be productive, taking care of themselves and those that they're responsible for. Okay. So maladaptive coping behaviors temporarily reduce stress, but often create new problems or worsen mental health. So would we say maladaptive coping behaviors are good or bad? What we say? Maladaptive coping behaviors. Are they good or bad for the person? They're bad, yes, because it only temporarily reduces or eliminates that stress. And so then that person ends back up in that spiral where they're not taking care of themselves. They may be spending all their money, giving away their car, they're not going to work, they're not eating, they're not bathing, and things like that. So examples of maladaptive coping behaviors is avoidance, attacking or bullying someone, excessive eating. It may even lead to self-harm. They even may even turn to substance use. Okay. So deep breathing, I think this is a repeat slide. Deep breathing is a technique used to manage emotional responses to stress, making an example of emotion-focused coping. So a lot of times when we're checking people's blood pressures, and that people are more aware of what that blood pressure is, and so they know they want that number to be good. And so what they do, I've been asking them to do before we check the blood pressure, get them in. We said, hey, come on, sit down, explain what we're getting ready to do. And with our one of the blood pressure machines that we actually use, it is set to take that blood pressure twice, and then it calculates and do a average of it. But what we do before we even start, we'll explain all that, because normally that's not what happens when someone gets a blood pressure done. So explaining to people, what to expect. And then after we put it on, everybody get in place, making sure your back is rested, feet are uncrossed, both feet flat on the floor. And what we do is ask them to take that deep breath in and then let that breath out nice and slow. Do that at least 2 to 3 times, and then breathe normally thereafter. Then we start the blood pressure. And even if we do still get a bad reading, patients have reported, oh, that just made me just feel just so much better in that moment. It's like, what, really? It just made me just rest, and okay, I'm okay about going to see that doctor. Most of the time, a lot of people are antsy or anxious about going and then to have that conversation with that healthcare provider. And so, we may still get bad results for that blood pressure. That deep breathing technique, is good for managing that stress. And they're stressed out having to come into that doctor's office, see us and everything, answer those questions that we're going to be asking and everything. All right, someone read this one.
Exercise is considered a positive coping strategy that can effectively help manage stress and benefit in individuals' health.
Okay. Yes, this is good, but we don't want people to exercise when it's almost time for them to go to bed. At least within 1 hour. Because the exercises, it gets things get to be elevated, that heart rate's going. It's going to take a minute. If it's like if they exercise and then it's time for them to go to bed, they may have a delay in going to sleep because the body has to refocus. But exercise is good. It's considered positive coping strategy. But then we don't want them to exercise too close to it's time for them to go to bed. Now, some people, it doesn't even matter. Like exercise, coffee. Some people say, hey, that stuff, drinks with caffeine in it. It makes me, hard to sleep, hard to fall asleep, things like that. Now, some people, it doesn't even matter. Drinking a cup of coffee, I can snuggle right on in with that pillow or exercising, maybe not a hard exercise, but like a nice little walk with a little bit of speed to it. Come on in, snuggle right on in. But for the most part, we do want them to not exercise too close to them going to bed. But it's considered positive. It allows those endorphins and allows people to de-stress and refocus. Okay. Coping is defined as an action directed toward change through conscious or unconscious thoughts and behaviors to avoid harm and to restore that balance. Because if this person is in balance, then they are more likely to be productive citizens, take care of themselves, those that they're responsible for. They're making sure that they eat a well-balanced diet, making sure that, if they're supposed to go to work, they're going to work. If they're going to school, they're going to school and doing those things that they need to do. So coping is those behaviors and actions that avoid harm and restore balance to the person. Okay. When conducting a history to assess stress, the nurse should ask about past and current state of health. We want to ask them, hey, how would you rate or describe your current state of health? They're like, well, I think I'm in control. And they'll say, I've been, paying my bills. I've been going to work. I haven't been staying up late. They'll tell you those things. Well, tell me about your past state of health. How would you describe that? And then we also want to ask them about their past medical history. They may be coming into us and they're exhibiting, hyper insomnia. They may be experiencing anxiety. We want to know what's their past medical history, because even though it's past medical history, it's still part of their history and things that we need to know in order to take care of the patient. And we want to also know about past and current medication in the event that it's deemed that they're going to need some medications. We want to know what medications they've been on the past. Did it work? Did it not work? Were you allergic to it? So we do need to know about past and current medications and past and current medical history in the state. How would they rate their state of health? Okay. The adolescent is at immediate risk for suicide because of expressed hopelessness and a clear plan. So if we had a list of people, different ages, the adolescent would be the one that would be at that higher risk. If they say they had a plan and the plan was to commit suicide. Safety is going to be our top priority. We want to maintain, if the patient is on one-to-one, we want to ensure that one-to-one is actually occurring. Even if the person is having to step away to use the restroom, it still needs to remain one-to-one. Someone needs to be able to relieve that person. We want to remove all harmful objects. That is going to be essential. Expected outcomes focus on safety and communication rather than premature denial of suicidal ideation. That person doesn't look like they haven't thinking about committing suicide. We don't want to make those statements or think that way. If they're deemed one-to-one, that's what needs to be happening until that one-to-one level has been relieved or take status has been removed from that patient's care. Although more teen girls attempt suicide, males are 4 times more likely to actually die from their attempts. That's just from the data that they have collected. Cultural norms that support or glorify violence can contribute to its existence within the society. Okay. Social isolation can increase vulnerability and reduce the likelihood of abuse detection, making it at risk factor for elder abuse. Okay. So, sometimes, our elderly, they've retired, and they're not out and about as they used to be. They just, even before you get to be elderly, sometimes you'll transition to like, okay, I just need to get in and get myself fed, make sure I'm clean and get a good book or watch TV. But they're at more risk because more than likely, they have slowed down for participating in things. And that in itself, that social isolation can make them more vulnerable for something bad happening to them. And something that we're talking about is abuse. Okay. We want to enforce professional boundaries and work within legal and ethical parameters. This helps prevent nurses from becoming victimized by clients and or their family members. So remember, I said, we want to be assertive with our clients. We want to be honest. We want to speak openly. We're not going to be disrespectful, but we don't want it to be, we want to establish those therapeutic relationships. We don't want to break the rules and things like that, because what happens is they may end up causing harm to us. And we're not sharing information with family members unless we have permission to share information with them. So in the event that family members are sitting in the room and we're getting ready to provide care for our patients, we want to see if it's okay for them to stay in the room. And if the patient says no, ask them to step out. Higher suicide rates are seen in survivors of natural disasters or severe acts of aggression. So natural disasters is, I don't know if you've ever, been where a storm has come through or, flooding, things like that. One moment you literally were going to work, coming home, going by the grocery store, providing for yourself, and that next moment it was not such a thing. We were talking about in one area, it's been now like 3 years, and there's still like there were several subdivisions, apartment complexes, and they're just now starting to rebuild. So just imagine being displaced. And a tornado is what actually had come through that created the disaster. Just imagine being displaced for 3 years. And so, you especially if you've grown up there in whatever place that it is, that's your hometown, that's like the only place you know. And nevertheless, that's where you have, made, your place that you call home. And so all of that, so to speak, is gone. And so that's why it's so important. You may be that nurse that decide to work with Red Cross and know that most of your responses are going to be in disaster. You're going to be, some disaster has happened. Now, like I said they do have the programs where there isn't a disaster, and they are what was it the fire detectors that we were installing in people's homes and things like that. But for the most part, Red Cross is focused on disaster relief. And so we do want to be able to identify resources quickly and readily for those individuals, because it could mean the difference of them going into a depression, and thinking about or being successful with committing suicide because of the losses that they paid. Now, we're not just talking about the run of the mill, like lights going out and a tree blown down in the yard. When we talk about a natural disaster, we talk about roofs, structures are completely destroyed. There's no lights, running water for days. It's a lot. But like I said, the Red Cross, they have other nonprofits and things that come in. I forget the name of it, and it goes nationwide, where it's actually like a laundromat. They have one that's like a bathroom, like they have inside these 18-wheeler and things, and y'all may have even seen them, where it looks like just a whole, like, wow, this is a shower, a tub, and this is a laundromat inside of this 18-wheelers truck. But they have those things, but over time, if you don't quickly get those people in a place where they're stable or as stable as they can be for a little while, then people kind of lose hope. Okay, so when used as part of a health history, the suicide assessment will yield valuable information about the client's suicidal intentions, if there are any, along with numerous clues about the individual. So I don't know if you all have done like intake at like the hospital and things like that. They ask those questions now. It's a whole list of questions that they ask. When used as a part of the health history, okay, I think I repeated myself. Yeah, I need to go back and delete that. Social cultural models have led to the establishment of long-term residential treatment programs in therapeutic communities. So with this being said, for the most part, we just think of urgent care, hospital, long-term care facilities, but there are all different settings out there that we can actually work in. And so the thing that you see trending now is long-term residential programs where people are coming out of their own homes and they're living in a place that looks like a house, but it's part of a treatment program. And what they found out, we make it more home-like, then it hopes that and assist with some of those stressors, like paying the bills, getting up, going to work, and we can get those people back in those routines and helping them in a more home-like environment that's more therapeutic for the person as well as the community. So we're seeing a lot of those. So the nurse just kind of stops by and go over the plan with them. They do like a check-in and everything, look at their medications, making sure that they've got refill. Hey, did you go to work today? What does your work schedule look like for the rest of the week? Just going over all those things and helping that person refocus and be able to manage all of their tasks. Effective listening skills help gain understanding of the client and establish trust, cooperation, which is crucial for therapeutic interventions. So this is part of being culturally competent, understanding what our clients understand about the disease process. What do our patients understand about taking these medications? Do they know that they need to come back and get this lab drawn? Because sometimes taking this medication may throw their thyroid function out of control. It may throw their glucose level out of control. So they know, does the patient understand? Do the patient understand? So we want to make sure. And how do we check off that they do understand? It's us listening to them. As we ask those questions, take time to listen and then restate, clarify, just to ensure what they said is really what they meant. Just making sure, you said that, you only need to take this medicine, once a week. Okay. Get the pill bottle out. Let's read what the directions say. So if the direction says this, how many times do you think should a person take this medication? And so taking the time to do that, listening to them, and then understanding, hey, this, even if they say a lot of times we get the medicines make them eat too much. They sometimes they think the medicine makes them feel strange, as we get that a lot. Listening to that and then giving voice to it and identifying coping mechanisms and or maybe a different medication for them is going to be beneficial. Okay. So these are just some theories. So they have, and as you have probably encountered all of your classes, you ran into a bunch of theories along the way. And this is not even half of it. But what those theories do, they attempt to explain the cause or what's going on. So these right here, so anthropological theories study the social history of humans. So it looks at, humans past, present, and up to this point, like what's going on with the human. So the psychiatric mental illness model, it views violence as a mental illness. So these different theories and then as you progress on in your nursing career, this is something that you're interested in, you may come up with a theory about, it didn't have to be mental health, it could be anything. Like Virginia Henderson, I'm sure y'all probably read about her in med surge. And in a couple of, you usually run into that theorist. And hers is either you're sick or well. So we want people to be well. If they're sick, what can we do to get them well? And so the theories are just different ways of just looking at information, making sense out of it, see if there's a connection, see if there is a solution. Okay. So we have domestic violence and dysfunctional families. Now, what makes a family dysfunctional is their ability to pivot, bounce back, their resiliency. So in the event that something happens, are they able to identify a resource in the event that something has happened in the family? For example, if the sole breadwinner, they're unable to work, are the rest of the family members able to identify resources? Are they able to get a job? Are they able to quickly come up with the next plan B, C, or D, so to speak? And if they're not, that's why they're listed as dysfunction. And then within that, it can lead to abuse in different forms because the family is not able to refocus and move forward with the next steps, the plan B, C, or D. Okay, so discuss ways to help families become more functional. So the example that I gave was the breadwinner of the family. They didn't lose their job, but they had a broken foot and they're unable to go to work for 4 weeks. So, what do those family members consider their plan B? Do they seek out resources? Do they file, that person may have an insurance where that little duck that they're able to, turn the claim in and then get the funds. So if the person has subscribed to that, with the next family member, or there are 2 family members that can step up and help with the bills, give us some examples. So in the chat, we want everybody to respond in the chat and then send this out so that everyone can look at it. So what you're responding to is list at least one way to help families become more functional. And that was just one example that I gave. So we'll put the timer on. We'll give you about a minute and 39 seconds. So list at least one way or intervention where families can become functional. Okay. And then send it out so everyone can see it. got a little time to think about it, formulate your thoughts, and then type it out. I'm gonna stop sharing so I can start looking at your responses in just a moment. All righty. Family nights, discussions. Hey, talking about what's going on and what each person can do. That check in with each other, improving communication. Yes, great ideas. Education, yes. All right, good. It's not that people don't think of that stuff, but sometimes people just don't think of that stuff when something happens to whomever that person is, that leader or those leaders that's in the family is like, what do we do? Simply sitting them down, having that conversation and asking them, hey, you know, what is it that you can do? So we know, this is going on. Just simply having that conversation with them. Great. Good. All right. These are just some characteristics. We see a person that's not able to have that resiliency, bounce back, so to speak. Communication is hard with them, because they just haven't, been able to or think through, well, hey, let me just sit down and think about this. They're just so focused on what's not there, that person, for example, that usually leads the family. Okay. So again, we mentioned this before. We want to ensure our client's safety and our safety. We don't want to leave our patients alone, and is a standard safety precaution when caring for victims of violence. We want to ensure their continued safety and security. So usually those people that come in and they have been a victim of violence, those rooms, they usually have, and I don't know if you all have rotated through the ER or not, but they usually have specialty rooms for those individuals. They're just not like sitting out in the rest of the, rooms as the others. But we do want to make sure, be thinking about safety, because sometimes the violator will come and try to continue to cause harm to that patient. They'll follow them to the hospital. So that's another reason why we want to make sure that we're following the policies. If the policy says one person come back, the policy says they have to be escorted back or sign in. Like, why do we have to sign in? We want to make sure that we're following these facilities' policies because they have it in place for a reason. And it is to protect the patient and the healthcare providers. Everybody on the healthcare team. All right, direct question may not be the best way to determine whether abuse has occurred, especially if the patient has just met the healthcare provider. So, we want to establish that therapeutic relationship. And so, but we do know that if you're doing like that triage, they ask all those questions. They ask those direct questions. But nevertheless, we do want to establish those therapeutic relationships with our clients. So in the event that they are being abused, that they will let us know so we can identify those resources for them. Okay. Individuals who were witness to and or a victim of interpersonal violence during childhood are at a greater risk of becoming perpetrators as adults. So what this is saying is people tend to do what they have seen because they're thinking that is the way that things should happen. It's like a learned behavior. Okay. Many times they report, well, this is how I grew up. And they think that, is how it should be. Creating a safe, private environment where confidentiality is assured is crucial for encouraging disclosure of interpersonal violence. So, in the event, we want to, like I said, that, in the event that we do see or there's an indications of this has happened, we more than likely not going to put them in that room It's a different place. You're in the ER, but there's a different place in there that they have people to actually sit and wait to be served. Okay, offering resources and support options empowers victims to make informed decisions about their safety and their well-being. Want to offer those resources, and let them know, hey, it's no wrong answers. Whatever you decide, we're going to support you in it. We have our case managers, we have all the people here to assist you. Okay, I duplicated that slide. And pull that one out. Client safety, not leaving the patient alone. Remember that? Don't leave them alone. Okay, so this is talking about effects of medications here. Okay, so tell me, what do mental health medications, what does it have to do with seizures? Do any of, and we're talking about they have a million side effects, but the ones that are mostly that a lot of people might end up having. So what could happen potentially when we're talking about seizures in mental health medications?
When you're suppressing the nervous system with like like benzodiazepines or
Mm-hmm.
um, they can cause rebound. Your body's used to being held down by benzos, so your body will be excited once you stop suppressing the nervous system.
Okay, and they're more apt to have seizures. Some medications do have those side effects with weight. And remember I mentioned that some our patients would say, "Hey, I just eat all the time. What's going on?" And then some of those medications, a lot of them, the patients complain of, and it's real. They do gain weight. And so, with that being said, if that's the medication that is going to that has been shown to have them at their best, then we want to have a non-pharmacologic intervention. We may want to say, hey, you might want to go ahead and get you a exercise program going. Join the Y, walk in your neighborhood, identify, go to the local park area. So a lot of times the open parks, they do have like a walking trail. They do have some equipment and things there, because we do know that sometimes they'll increase, their weight will go up on some of these medications. What about hyperglycemia? What are we seeing with some of these medications in reference to hyperglycemia? Or is nothing happening to their glucose levels? Are we not seeing anything with that? You don't want to answer, or you don't know, you are. Is anything happening to a person's glucose level that's on some of these mental health medications? Do we know? Is it affecting it any? Let's see. Someone put something in the chat. Uh-oh.
Can they go up and down?
So, see, okay, he's not sure. Yes. So what happens is some of these meds, it makes their glucose go high, and they end up, it kind of like throws them into diabetes. So we want to make sure that they're coming in and getting um their labs done, because remember, if we're getting those routine labs, then we're going to see those glucose levels. And then, like someone else put in the chat, remember, some of these medicines are making them eat more than usual, so they're having a more higher calorie content, maybe high carb content, and all of the above, which is going to be a direct correlation, especially if they don't have that exercise program and they're not burning up those calories. What we're going to see that extra glucose, and it depends on what food items they're having. So yes, the antipsychotic agents, they may lower the seizure threshold in patients with seizure disorders, and even in those that have no history of seizures. So we want to tell them, hey, if you're feeling different, if you're, get some examples, because not everybody have the jerking movements. If you're having what they call auras, like you're seeing or hearing things, if you're having just like a change where you're just not feeling well, because some people say they have like blank stares and things like that, we need to know because it could be that this person's having a seizure, even though they don't have a history of it. We hate that. That's what some of these medicines do, but because we know that it does that, and most of these meds work really well in getting that person back in the swing of things, so to speak, back taking care of themselves, going to work, and all of that. We just have to educate them, as someone just mentioned in the chat, about this. The antipsychotic drugs, like, I don't know if I want to take these things. I have to buy a whole new set of clothes. Well, we want to, since we know that, we can go ahead and let them know so they can start, doing some things to burn up some of those calories, and even maybe bring it to their attention. Well, hey, it's okay to just eat half of that now and the rest of it later, or just be mindful that your appetite may be a little bit more, and you may want to add more water in your, in your diet or whatever. And as a result of that, it's like a domino effect. It can lead to diabetes. Exactly. Bradycardia, electrolyte imbalance, presence of congenital prolongation of the QTC interval. Now, all this is heart related. A person may also be experiencing, yes, their appetite, heart, chest pain, or chest discomfort. We don't want to take that lightly either. If they haven't been experiencing anything wrong with their chest, that person probably needs to come in and get an EKG done, because it might have affected their electrical rhythm of the heart. And like I say, it's like, wow, why am I taking these meds? These meds are making me sicker. The potential is there. Not all of them do this, but the potential is there. And we rather make them aware of that these things could potentially happen. All right, so we're gonna pause and take our first 5-minute break. We'll push most of our time toward the end, but we'll stop and just take at least 5-minute break, stretch, get some water. Remember, this video still plays, so make sure your cameras are off and that you're on mute. See you in 5. So come back at 6:38. Okay, we're gonna actually pause and do a Kahoots. Give me just a few minutes to get it pulled up here. All right. Are there any questions about the concept as we went over so far? So pretty much narrowing down things, we're fine tuning things for our exam for next week. Anything that we still have questions about? I know you all had some questions. You all said that you really wasn't sure about the effect of these medicines on glucose and weight, things like that. So is there anything else, any of those other concepts that we've talked about this evening that I need to go back over? Okay, I get my little password, y'all, to log in. What are these cookies, these things we talking about? The cookie settings. And then if
Cookies
you,
make it easier for you to search things.
okay, because I'm trying to log into Kahoot and it wants me to accept the cookies. So hold on, you all. Hold on. Something's going on inside of here. Hold on, you all. If I scream, I need y'all to call 911. Hold on, hold on. Oh my goodness. Look. I had just went to the door, you. I just made sure my doors was locked. And I'm not obsessive compulsive. But I said, let me just make sure these doors are locked. And so, anyways, it actually sounded like someone had came in the door, but I don't see anyone there. But
Oh, I
anywho,
check my doors like twice before I go to bed. I'm weird about that.
I was like, oh, then I heard this stuff like, oh, somebody what? I thought I turned the latch, but anywho, I'm okay. What was I asking? Oh, the cookie thing. So I mean, I've logged into Hoops I don't know how many times. And why is it asking about these cookies? Is it will it not let me log in and use the Kahoot if I say reject?
You might need to clear your cache.
Oh, that'll cache thing. Okay. All right. So let me go over here and see. I may have to move forward and come back to this Kahoot. But anyways. Wait, it's spinning, so give me just a moment, you all. And I might have to just do Kahoots back to back after toward the end of our second hour, because it's still spinning for some reason. Let me see. Let me refresh. So as I mentioned when we first came in, we're creating these flyers to post on social media. We're creating these flyers. We're doing a health fair, and we are creating these flyers to pass out to the participants. We're doing that. It might be primary because we're educating people, but it might be tertiary intervention. Even though it's a flyer, it's still education, but we know it's tertiary if a person already has a disease process or injury or something. So, but nevertheless, we're creating these nice informationals. They're to the point, just like about the weight gain, making sure they come back and get their labs done because medications have a risk. I may have to do, okay, it's opening up now. They may have a risk of diabetes or seizures. And so, and I said that so that you can just start narrowing down, fine tuning your understanding of the concepts here. Generalized anxiety disorder, obsessive compulsive. I'm telling you, I don't know what's happening. Well, let me see. It was let me in, then it wasn't let me in. Okay, we may just keep on talking. Okay, we'll go ahead and look at some more slides, and I'll try to find it, log in at another time. I'm clicking it one more time. This doesn't work with me before. And everything's want access to everything. You log in one thing, and it wants access to all your stuff. No. Okay, it's opening up. Let me find the folder. That I placed it in. And we will look at all of our Cahoots. So we want to review, and then still next week we want to review again so that we have it. But now I don't see my folders. Okay, let me go to my library. Okay, here we go. All right, I'm with you now. Here we go. We will. Hmm. Looks like, okay, here we go. Here it is. I think maybe some of it was connectivity too, but it's loading now. So go ahead and go over to the Kahoot. It will actually do two, and then we'll come back and look at more content because I think we have a total of 6 or 7 to look at. And I'll try not to talk during the Kahoot, so therefore you can focus. And don't try to answer the fastest. Make sure that you're reading the question that's there and answering the best to your knowledge. And then take notes of those concepts you need to go back and look at. All right. At least log in with your initials. You don't have to put your whole name. I think we have everyone, and let's get started. This includes you all getting them to their doctor's appointments as well. Most people don't think of it as that, but getting them to their well checks, if they're diabetic, doing those follow-ups and things as well. That's basic needs. This is an example of making sure that we read the question, because sometimes our thoughts will go faster than what we're reading. So remember, you have that whole 75 minutes to take the exam and make sure we're reading and answering, reading correctly. Because what would make this statement true if we flip what two words if we flipped it would make this true?
You said men and women.
Exactly. If this was perpetrated by men to women, this would make it true. So just, when we first saw intimate partner violence, read is the entire statement, a question, and then decide on what it's really saying. Like it's like paraphrasing it, looking at it for clarity. Okay, this is false because this is women to men, but had this said men to women, this would actually be true. Okay. Uh-oh, what did I just do? Okay, let's do one more and then we'll move back into our content to get it pulled up. It shouldn't take me as long this time. Come out of this one. Go. Got it. And I did see your responses in the chat. Some of you are responded to that question in the chat. All right, log in and let's get ready. And we have everyone, and we will start. Hey, you all, we want to go ahead and tell our patients, hey, you will experience this. This is not for fake. This is real. So we want to go ahead and let them know so they can make an informed decision. Okay. So remember they call it roofies for short, and there might be other names, but I know they say roofies, and that because they're referring to what is actually in the date rape drugs. So another test taking tip, they use the word not, but is another one, and then all. So be careful, be on the watch for those words, not all, but. And there are some others, but just make sure you're looking for those because it may change what you're thinking your answer should be because it says which of the following is not considered rather than considered. I don't know if you recall, we were talking about making sure, checking the environment, making sure that the environment was desensitized. Maybe we may have to turn down the lights a little bit, making sure, the temperature is just right, not too cool, not too warm. There's a person that's going through what we often say DTs. They may see things, hear things, smell things that are not there. Um, and so we want to make sure that we're considering safety as well, because think about it, if they're seeing things and they think something's running after them, or if they're looking at you and they think that you're a bunny rabbit or the devil or whomever, then they may attempt to cause harm or get rid of, because they're not seeing you as a person because they're hallucinating, they're delusional. So we want to make sure we're thinking about safety at all times, especially when they're going through DT for the patient and also for the nurse. All righty, we'll go back and look at our content. Let's see who or our top Scholars. All right. All right.
You raise your hand, Jalen.
Hmm. Was there a question? No? Okay. All right. Here we go. Let's pick up where we left off. We were talking about the effects of, these medications help one thing and, they hurt something else. So it's important that, we, do that reinforcement of education with our clients, making sure they have those written instructions so they can refer back to and or letting them know, hey, if you still don't understand or recall, actually call the facility back. But coming in, getting those routine labs, including EKGs, getting that glucose level, that hemoglobin A1C done because of the weight gain, the increase of calories that they'll intake. And so it's important that they come back and get those labs done routinely. Okay, so what about lithium? What does lithium do to the thyroid? It makes it not function like it's supposed to. Long-term side effects of lithium can include thyroid problems such as hypothyroidism. So that thyroid function should be another test that they routinely draw up. So it's real important they have their follow-up appointments, making sure they come in and get that lab work done. Yes. Consistent fluid and sodium intake helps maintain stable lithium levels. So we don't want them to be adding salt to their diet, but just putting that normal salt content in, not adding more than it should be. Sudden changes can lead to toxicity or reduced effectiveness. So we want to make sure that they're taking those medications as prescribed also. So consistent fluid and sodium intake. So they want to be careful with I know it's summertime. If they're not out sweating and, losing those electrolytes, drinks like Gatorade, Powerade, those things like that. They don't want to just be drinking those just as, just something to drink. And true, now, if they're out cutting the lawn, they're out in the park and they're sweating, they're losing those electrolytes. Yes, we want to replace them, but that's not a drink that they should be drinking if they're not losing those electrolytes. Because what's going to happen is they're going to have too much sodium on board, and it's going to, if they're on lithium, they're going to end up and being toxic. Okay. So benzodiazepines, we want to, with all of our medications, want to make sure that we're teaching our patients about them. They can cause rebound anxiety upon discontinuation, have a potential for dependence, making them unsuitable for long-term use in most cases. So this is a medicine that we put people on for short term, not long term, because of that rebound, and also because the person may become addicted or dependent to these medications. Benzodiazepine overdose is characterized by that CNS depression. All those things are going to be decreased. So they may not be alert. They may be experiencing slurred speech. So, when we're taking that health history, we don't, because this right here can benzodiazepine overdose can mimic a stroke because that person literally has that slurred speech and then they don't have that they are not as alert. And so we want to make sure that we're writing down and getting their medication history too, like what meds are you on, so that we can look at and determine, well, hey, is this true stroke symptoms or not? Because some of these medications can mimic other disorders. Nurses should be vigilant for the signs of toxicity when administering these medications and report concerns immediately. Okay. SSRIs typically take 4 to 6 weeks to reach their full therapeutic effect. This is another thing we got to tell our patients, hey, you might not see improvement until after that second week, but the full therapeutic effect might not take place till 6 weeks. So continue to take it and let us know how you're doing. Do your check-ins, but let them know. You might not see that full effect within those 3 weeks. And that's seem to be like a long time, which it is. So just let people know so they won't be thinking, hey, they just ordering me something. They don't know what they're doing. But just go ahead and let them know about that time frame. Patients need to understand this to maintain that medication adherence. Because otherwise they're like, I'm not taking one of these meds. So what about if they miss them? They need to take the missed dose as soon as remembered, unless it's too close to the next dose. Like if it's within an hour or two, I would even say within 4 hours of taking the next dose, they just want to wait and take that next dose. But go ahead and take it. If it's like a day has went by and it's not due to a whole nother day, go ahead and take that next dose. Because we do want to keep those levels as therapeutic as possible. We talked about that weight gain. It's a common side effect. The nurses should discuss diet and exercise strategies and the possibility of medications adjustments. If they're gaining too much, we want to look at just taking, see can they be prescribed something else. So it's important that when they come in, they're getting those weights done. Okay. So gender abuse. There is no typical abused woman. Characteristics of an abused woman: trusting nature, raised to be non-aggressive, and traditional beliefs that the man is the master and protector of the household. Characteristics of an abuser of women: poor emotional control, superior attitude, history of substance abuse. Substance abuse plays a huge part in a lot of these different areas here. Abuse during pregnancy. For some women, pregnancy only increases the chances of them being abused. The frequency and severity of abuse, as well as their potential for homicide, are significantly increased for some women when they become pregnant. Effects can be devastating. It leads to preterm deliveries. The person might not even be going for their prenatal care because the person may deem that as a way of punishing the lady. You're not gonna go get your prenatal checks. You'd be surprised how people will come up with ways to cause harm. So the most vulnerable individual in society is going to be the children. Usually we think of the children and the elderly, but if we had to decide between the children and the elderly, we're going to select the child every time because they're the ones that's going to solely rely on someone else providing for them. So they are the most vulnerable population. Remember, we talked about the different forms, but neglect, that includes making sure those babies get to their well check appointments, the dentist, and all of those things. That's part of providing that care for them, being responsible for that child. The rate of abuse of adolescents surpasses that of younger children. We said that early on. And with the 3 leading causes of death, fatal accidents. A lot of times they're not wearing those seatbelts, driving at high rates, maybe substances on board, murder and suicide. Vulnerable older adults, those with chronic or disabling illnesses, those that don't allow them to be able to take care of themselves as they normally would without assistance. And so that puts them at risk because a lot of times they're kind of, weaning away from, everybody anyways, a lot of routine activities because they have become older. And so a person might not even know that this person needs assistance with baths and going to the grocery store and getting those groceries and everything. Family members are the most frequent abusers, though, of older adults because usually that's the people that's going to be, they're going to let in their house, in their homes. And you do see the financial abuse where they spend their phones and everything. You see that a lot. Sexual abuse, unwanted sexual attentions of another. Healthcare provider should routinely assess all clients for a history of abuse or victimization and report any suspicious signs or behaviors. Report that. Violence and trauma and crime. Today's society is confronted with a steady diet of violent behaviors. You just hear all different kind of acts. It's like, how do they even think of that stuff? Why is that even on their mind? So the basic needs of trust and autonomy are threatened when one is involved with violence. Okay. Group abuse. Aggression against certain groups occurs in subtle ways. So they'll identify, just random groups of people. The ladies that go to the walking club, the people that go to this church, but they identify groups to actually cause harm to. These forms of aggression against members of certain groups are quiet, subtle, and usually unspoken, but they still influence the lives of many good people. You know, people that's going to the movie theater, they're going to the skating rink. So we have the DSM-5 defines only one clinical syndrome as directly related to violence, and that one is the post-traumatic stress disorder. Okay. Rape trauma syndrome, a nursing diagnosis that encompasses the essentials of care for victims of this experience. Recovering from being the victim of rape follows same steps as are seen in stages of recovery from other violent acts. Okay, some goals. We want to prevent violence from ever occurring in the first place, early recognition and treatment of violated individuals. You know, if we have encounters with persons that, you know, that may have not so good social skills, you know, their responses um or their responses are not reasonable, then we want to be identifying resources or coping techniques to assist that person in being sociable and expressing themselves, even if something's going on that they don't agree with. So we want to give them those soft skills. Okay. Treating victims of violence, we said do not leave the victim alone, explain all procedures, make sure in terms that they understand, and allow the client to maintain as much control as possible. Hey, you know, I need to check your blood pressure, so I need for you to remove your arm from up under the cover. Or if you're getting ready to turn the cover of the sheet back, let them know before you do it, which we're doing that anyways, but for sure, someone that has is a victim of violence. Okay. It's important to remain aware that violence can erupt in any client situation. So when interacting with clients, watch for signs of growing anxiety, frustration, and agitation. You know, watch those nonverbal cues. Look at that. If they're frowning, if they're, you know, balling and making fists, you know, they are, you know, just look at all those different cues as their voice tone changes. We want to seek assistance from other care providers when needed. We want to enforce professional boundaries. Okay. Learn to recognize those aggression and violence in our own personal thoughts, attitudes, and responses. This patient is experiencing psychotic symptoms. I'm not sure what this is, but I think I probably had a scenario or something on a previous slide, but I was cutting and pasting and stuff, so I may have missed this part right here. So, but nevertheless, the nurse's priority is safety and therapeutic communication, keeping you safe and the patient safe, making sure that we're not speaking in a demeaning tone, making sure that our voices are not like high pitched, raised, and that we're not sounding aggressive. We want to be assertive, honest. We're not being rude. We do want to acknowledge the patient's emotions, shows empathy, while avoiding validation of delusional beliefs. So we want to listen to them, but we don't want to say, yes, we do see the bugs crawling on the wall. In fact, if we don't see the bugs crawling on the wall, you know, we don't want to endorse things that validate things that are not correct or true. We do want to reduce the environmental stimulation that decreases that agitation. You know, if it's noisy, you know, we may have to move them to their own room. If they're in the room with someone else, they're sharing a room. Over time, outcomes include reduced anxiety, and then just think about keeping you and the patient safe. So subjective data in mental health assessments relates to the patient's perceptions, feelings, and experiences that cannot be directly observed or measured. So whatever that patient is telling you, you know, the patient says, you know, whatever that, think about like the delusions of grandeur, like the example that I gave. If they're saying those things, we capture everything that they are saying. You know, it might not, we know that some things, that example with the, when I said the patient said that they were actually dividing the mountains and things like that. We know that they're not doing that. But we still write that down because we want to capture that their thought process is not rational. Okay. The patient's report of feeling anxious and restless is subjective. as it is based on that patient's internal experience. So we still write the patients report that they're anxious, can't concentrate. And then we can also list those nonverbal things. For example, if we're having to ask the question several times, or if the patient is standing up and down, up and down, we want to include those, give a clear picture of what's actually going on. Okay. A thorough medication history helps identify potential drug interactions, like we talked about a couple of slides back. Making sure that we have that past and current health status, the medications, if they were on past medications, and if they were stopped, if they were informed to stop taking medications, as what was the reason, so we can list those. Are there any medications that you're allergic to? Any foods that you're allergic to? Like, those are just standard questions. You do want to write those down. And a person said that they're allergic to something, ask, okay, what did you experience? Because people do experience different types of reactions from medicines that they're allergic to. And what they'll do is they try not to pick a medication that's in that same class or that's made out of those same ingredients, because more than likely that patient's going to, more than likely, if they're outright allergic, going to have those same responses to them. So cultural competence demonstrates awareness of cultural differences and a willingness to adapt the interview approach to better meet the client's cultural needs, promoting effective communication and accurate assessment. So we do want to make sure that we're taking the time to ask those questions, more focused questions. If they answer yes to something or no to something, in the event that we need to find out more information, take the time to find out that more information, because remember, we do want to provide the care based on their preferences and also their needs. So how are we going to do that? By finding out more information. And that means that we're being culturally aware and competent. Simple, concrete questions are easier for patients with disorganized thoughts to process and understand. So break it down, make it as simple, as easy to understand as possible. Because if a person's already, their thought process already disorganized, jumbled up, explaining something so elaborate and not in terms that they can understand, is going to lead to more frustration. And it might make the person act out because they feel intimidated because we're saying things that they just don't understand, and it's more confusing to them. So if we simplify things, this helps maintain focus and clarity during the assessment. Okay. Are there any questions about that content? Made it through that one. Any questions? All right. So let's pull up another Kahoot. Then we'll move on to our other PowerPoints that we have. Not seeing any questions in the chat. Okay, I'm trying to share you all. My little, okay, there it is. My cursor was doing something. All right, so log in and let's Kahoot it. Okay. All righty. Let's look at some more content here. Is it? Yeah, not time for a second break yet. Trying to get it pulled up. So, another thing to decrease anxiety in reference to preparing for the exam, you all, usually those exams are open a couple hours before we take it. So make sure that you're downloading it, making sure that you have your two devices and and your chargers, making sure you have those things. Okay, it's pulling up here. Okay, I do see the announcement. Dr. Book actually, Color actually posted on the first. There will be an exam review on August the 9th, and it says at 2:30 Eastern Standard Time. So if you are unable to attend it live, she posted the recording. So just make sure that at a minimum that you commit to going back through our classroom recordings and that exam review recording that she will post if you're unable to attend. Even if you do attend it on Sunday, just still make sure you go back through our classroom recordings and that exam review. Because there's that repetitiveness of just looking at those concepts, looking at it and hearing us talk about it, going back and forth over and over. It does help. All right. It is pulling up. Now this one I didn't break all the slides into little bits and pieces. Just left it how it was. And one thing I did was just added the color to it. Because some of their slides are just full of information, so I just break it down. All right, and then some of this information is going to be repetitive, but nevertheless, we'll get it here. Let me share my screen. All right, so continuum of behavioral responses. Okay, so we're talking about the inward focus emotions. We're talking about suicide. We kind of already started talking about it. So maladaptive self-protective responses, if not changed, eventually can lead to self-destruction. So we said maladaptive were those things that provide that temporary relief, but it was not a long term. And what it does, it actually increases a person's anxiety. So we're talking about maladaptive self-protective responses. And so over time, it can lead to self-destruction. Okay, myths about suicide. Suicide has always been present in society, but little effort was made to understand its nature until the beginning of the 21st century. Remember, myths are things that are not true. Many false ideas about suicide exist. People who talk about it would not commit suicide. That is not true. One does not need to take a suicide threat seriously. That is incorrect. Only psychotic or depressed people commit suicide. That is incorrect. So myths, these are all this slide is telling you things that are not true if someone is saying that about suicide. In fact, if they do have a plan and they are saying it, then in fact, you can take them to be serious. It's the 10th leading cause of death in the United States. It is real. It's important for nurses and other healthcare providers to be well versed in recognizing and intervening with clients who are suicidal. We want to make sure that we are finding out as much as we can about our clients because remember, it's them that's receiving the care anyways, and in that way we can come up with interventions that are most suitable for the client. Customs and rituals may play a role in suicide. Many social influences affect the incidence of suicide. Social isolation, inability to meet basic needs. Something has happened, the person just can't take care of themselves, food, water, and shelter, the availability of weapons, one state of health, people who have been deemed with a chronic disease. Not only HIV and AIDS is listed here, but someone that has been listed as having stage 4 COPD. They've been deemed terminal, things like that. Different disease processes like that may influence a person to think about or actually commit suicide. So being aware of these social changes in the world and just being aware of what's all going on with our patients and seeking out those resources and pointing out those resources is going to be essential. Okay. Characteristics of suicide, physical dimensions. Thoughts of suicide produce many of the same biochemical changes in the body as with someone that has depression. Some of those same biochemical changes happen. Clients are filled with feelings of ambivalence, anger, aggression, guilt, helplessness, and hopelessness. They just lose all hope. Intense emotional suffering leads to distorted thinking and self-defeating thoughts. Includes one views of others, and then cultural, religious, and ethical dilemmas associated with one's own demise. All right, so we're going to stop here, and we will take another break. So we've taken 2 already, so we've used 10 of our minutes. So we will return at, time is it? Return at 7:36. Remember, this video still plays. Turn your cameras off and make sure you're on mute. See you at 7:36. All right. We're almost there, you all. And so let's see here what we picked up at, or we left off at rather. Let me share my screen again. So getting ready to call on you all to help read some of these slides too. And some current slides. Okay, we went through that slide. Okay. So dynamics of suicide, categories of motivation. Suicide victims share two major viewpoints: deep despair, poor self-esteem, and feelings of being trapped. Relief from miseries of this life and need to connect with immortality. It's like they just don't, there is just no help, no matter what insight. It a cry for help, refusal to accept a diminished quality, style, or pace of life, need to affirm one's soul, relief from distress. So they look at the suicide as being or just a relief from all the troubles and things that they might be facing. Okay, so someone read this slide right here for me.
Effects of suicide on others. Suicide has a strong effect on those left behind. Survivor guilt. Survivors often think that they could have done something to prevent the suicide. Anger may be expressed. Socially, the stigma of suicide is felt. The survivors of suicide, no matter who they are, must grieve and learn to heal.
Okay, thank you. So it's just not the person that actually commits suicide, it's those that are left behind. It affects them as well. So these are those theories, and you all did pretty good about identifying them on that Kahoot. And so let those some test taking tip, the social logic theory, all those things that the examples they had listed were social things about a person. So let those some things you can identify based on those root words. Some other things, you have to just know outright. But these are those theories. Okay. So all right, someone read this slide for us.
Suicide in children. Suicide in children is most often the result of family conflict or disruption. Suicide in children usually is not planned. Any child whose attitudes, behaviors, or habits change dramatically in a short time, especially following a stressful event or situation, is a candidate for suicide.
Okay. So it's really important that we have open communication, ask our children to have open communication, let us know whatever it is, good, the bad, and the ugly, as I say. And also those social skills to set up barriers, that it's encouraged, know that they have self-worth, things, improve things, and let them interact, and also make sure that we strengthen or do things to empower them and improve their self-esteem, that their self-worth is not based on someone saying something about them, and so laying that strong foundation. And then, if the family is going through some things, not letting the child know all of the things that are going on, that might be a better option. Because if the adults are struggling with finding resources or being able to pivot and move forward, just think about a child whose brain hasn't even finished developing yet. Just think about them dealing with whatever the disruptions are, what's going on within the family as well. How they're able, what would they think about that? How are they able to handle it? It's a lot. It's a lot for an adult. So you can imagine it'd be a lot for the child. So maybe limit or not just only share certain parts of what the family is experiencing, because like I said, the child's brain is still developing and they just haven't learned those coping skills just yet. They're learning though. Adolescents, especially those with low self-esteem, may consider suicide as an option for solving their problems. Adolescents with anorexia nervosa have a higher, and this is just from statistics, have a higher rates of suicide. Those that have anorexia nervosa. Suicide is a significant problem in adulthood. Women attempt suicide 3 times more frequently than men. Men are more successful at completing the act. Loneliness is a factor in adult suicides. Do not hesitate to ask clients if they ever think about suicide. If they say yes, seek out resources immediately. Okay. Suicide in older adults. As age increases, so does the rate of suicide, passive suicide, refusal to eat, drink, or cooperate with care. I'm not sure if this patient actually was, trying to attempt passive suicide, but once we took their history, so the patient was a diabetic. I guess after about was the third day, the family said they haven't heard from the patient, so they went to the patient's home. Of course, they found the patient. I think the patient was in the bathroom, and they called EMS. EMS came, and their glucoses wouldn't even register. But as we were taking the history from the client hadn't eaten in days, hadn't taken medication in days. Wasn't because they didn't have it and didn't understand how to take their medications, but the patient never said anything about suicide. They just thought that they just needed to do something different. This is how they phrased it. And then Sue really wasn't sure, but we still, even in that instance, we still called upon our resource, case management, to site to actually evaluate this client, because we just really wasn't sure, because if this client didn't say that they were going on a fast or anything, so it really wasn't adding up to us. So passive suicide is a thing too. Older adults tend not to communicate their intentions unless directly asked. So we have to ask those questions if it's on that questionnaire. Most older adults view timing of death in one of the following ways: God control, physician control, individual control, or control by the individual alone. So nevertheless, we are, okay, that's fine. We do want to ask. And like I said, the thing when we're doing those histories and things are just quite not adding up and we don't understand. Like I said, we were like, well, why wouldn't you? Well, you're on a fast, because people do fast. And what that means is they don't take or eat certain things. But that wasn't why this person was not eating or drinking or taking their medication. So they didn't outright say the word, they were planning suicide, but those actions, do you understand what happens when you don't take your medications, you're not checking your sugar? They understood all that. So translation, let's get you an additional evaluation, some additional resources so that we can assist you here. Okay. Go back to that. Therapeutic interventions. Thoughts about suicide can be described by suicidal ideation, threats, gestures, parasuicidal behaviors, suicidal attempts. The last level is is completed suicide, the successful attempt to end one's life. So motivation for successful suicide may be conscious or unconscious. And so that's why we want to at least ask that question. Like now, our questionnaire includes asking people, do they feel safe at home? Because they may know, but if you don't ask the question, they don't say yes. So, they might not say that they really are not safe at home. So that's the question we've started asking as well. So preventing suicide from occurring means saving a life. Assessment of suicidal potential. Evaluate every client for the potential. Assess risk factors for the age of the client. Ask the client directly whether he or she has any thoughts related to suicide. So the suicidal assessment, are they having any thoughts? Are there any history of attempts? Is there a plan? Availability of items to carry out a plan. So think about the settings that you've rotated to and that you may be considering working in. If we are working on certain units and things, we want to make sure, looking at those rooms, if the facility policy is not to have certain things in those rooms, make sure we're following those policies. Because if certain items are available, that person may carry out that plan. If they're using substances, if they're abusing substances, what is their thought process? How do they feel about what's going on in their life right now? Do they feel hopeless? Have they lost, they feeling feelings of despair? Can we seek out resources that might assist them? And this is all jumbled up here. These are our nursing diagnoses that might be on a person's care plan. I think when I did the design, it kind of all went together. Okay, someone read this one for us. Therapeutic interventions.
Therapeutic interventions for suicidal clients. Interventions protect from harm. Take suicide precautions, establish rapport with the client, make a no self-harm agreement with encouragement and advocacy of their caregivers. Many suicidal clients are able to develop effective strategies for living satisfying lives.
Okay. Are there any questions about that content? Are there any questions? Where is my little? We're going to try to do another Kahoot. Here we go. All right, log in, log in. Here we go. All righty, let's rock and roll. All right. So that question, remember the answer, that other answer choice looked like it was supposed to be correct, but the last part of it didn't match because it was the parent imposing it on the child. So it was fictitious, imposing it on someone else. The other answer choice says fictitious, imposing it on themselves. So make sure that you're reading through. That other answer choice did not match what the scenario said because it's the parent on the child, so that's someone else. So just make sure that you're reading it through. Okay, let's move on. Get this one turned off. Oh, there it is. I'm looking for. Okay. Okay. And we have went over some of this too, but we'll just make sure we got it. Slideshow. Current slide. Okay. Psychotherapeutic drug therapy. Okay, I may have to zoom in on these to make these larger. Okay, so psychiatric medications act on the body's nervous system primarily by altering the delicate chemical balances within that system. Most interrupt the chemical messenger, that those neurotransmitters pathways within that brain. Most of them block those transmitters or they rewire. That's how they make those, that's how those medications are effective for that person. A primary responsibility of the healthcare provider, especially nurses, is to differentiate therapeutic from unwanted effects. So we do need to be talking to our patients, making sure they're letting us know how they're feeling, what they're experiencing, so we can tell, hey, if this is an unwanted effect or is this a therapeutic reaction um, to the medicine. Okay. So we have anti-anxiety, antidepressants, we have mood stabilizers, and antipsychotics. People who are receiving these medications must be monitored routinely for effectiveness. Are they working? Are they experiencing any side effects? And then remember that there are also some life-threatening adverse reactions. So we want to make sure that we are monitoring these clients routinely. Anti-anxiety agents are drugs that reduce or decrease the psychic tension of stress. Analytics or minor tranquilizers. Medications in the anti-anxiety group are divided by their chemical formulas, how they're made up, how they're divided. So benzodiazepines mainly used to decrease or reduce anxiety, act by increasing the gamma amylbutyric acid GABA activity, which results in decreased anxiety. So it increases the GABA activity, and as a result of that, it decreases anxiety. That's how it works. Because long-term use of these anxiety drugs can result in dependence, we want to make sure that we are identifying, those positive coping strategies and things for these clients, and making sure we're on the lowest dose possible, and seeing if there's some other medicines out there, because those are become highly dependable. People get dependent on, they get hooked on them, so to speak. So Buspar belongs to the azathioprine drug class, does not cause the sleepiness or muscle relaxation associated with the benzodiazepines. Therapeutic effects may be seen within 3 to 6 weeks. So again, making sure that we're telling our clients, hey, you're not going to see the full effect for a while, and let them know it's going to be up to 6 weeks. So Lyrica side effects are fewer than those of other anti-anxiety drugs. So patients are more likely to comply with this treatment. They're not seeing all the sleepiness and the excessive muscle relaxation with the Lyrica. Now, some of these medications, I know you probably recognize, you didn't may have thought, well, I didn't know that those were anti-anxiety meds. Your patients might not have been taking them for the reason that these medications were designed. What happens is, excuse me, a lot of medications, people are taking them and we found out that they work so much better for other diagnoses and other things that's going on with patients. So, but they were designed for anti-anxiety, but they're off-label uses. So you will see people taking these meds for things other than what they were actually designed for. But nevertheless, we still want to make sure that we are getting, asking those questions. How are you feeling? What side effects are you having? And making sure we're making note of those. So that CNS depression, we want to make sure that our clients are knowing how these medications are going to affect them before they're driving, operating heavy machinery, and things like that. And also this one right here, you all, some of these medications, if a person is taking antacids, they bump heads. It will make it interfere with the absorption of these medications. So this patient's like, I'm not getting better. It's been more than 6 weeks. We need to ask, what other medications are you taking? Are you taking any over-the-counter medications? You know, so whatever they are, but know that antacids do interfere with these anti-anxiety meds, make them they're not able to work like they're supposed to. Antidepressant medications act on the body by increasing certain neurotransmitters. Some of them decrease and others increase. So the physician's first choice for treatment of depression is often an antidepressant. And they do have the different categories. The SSRIs, they had the atypical antidepressants, the tricyclic antidepressants, and the SSNRIs, norepinephrine reuptake inhibitors. And it's just saying that's how they work. They inhibit that. Antidepressant medications may be taken 1 to 4 weeks before symptoms relief is noted. Usually is longer than the 4 week. Maybe around the 2.5 mark, you kind of start seeing, but nevertheless, just give them that range. And so they won't think it's an immediate, so they won't stop taking the medication. So here it is. We need to tell them about those side effects. That dry mouth, that's a real thing. So we need to be thinking of things that we can offer them to take that may offset the dry mouth, the nose and eyes becoming, so dry. Urinary retention, we need to know that. The person already has, excuse me, you all, excuse me, hypertension. They need to be making sure that they're checking that blood pressure, because these medications can tend to increase that blood pressure, making this person more at risk for stroke and heart attack. So I'm going to make sure that they're taking as prescribed, but they're also watching out, screening for to make sure that that blood pressure is not getting to a dangerous level that's putting them at risk for something else bad happening to them. We kind of talked about lithium, naturally occurring salt used to treat manic phase of bipolar. So we talked about the people, if they're not, excessively sweating or losing electrolytes, those sports drinks, they want to stay away from those because we don't need any extra salt if the person is taking lithium. It's important for clients to balance their salt intake, their food intake, and their activity. And also making sure that they come in and get their labs done. This is one that they look at labs to see if those levels are therapeutic. So antipsychotics are also called major tranquilizers or neuroleptics. They used to treat symptoms of major mental disorders like schizophrenia, acute mania, and resistant bipolar. Okay, again, the antacids, they interact with those. The alcohol, it interact with those. We saw that on a couple of sides. They do interact. So we want to make sure that we are, doing our assessments, writing down our verbal, nonverbal cues, what the client is saying, so we can make sure that this client is not experiencing any interactions. Okay, this is some examples of those SSRIs. Okay. So some things that we need to make sure we do: assess the client, want to coordinate the care, administer the medication, monitor and evaluate responses, and then provide that client teaching. Explain in the terms that the patient understands. Remember, we're healthcare professionals, so some of these terms and things that we might use when we're talking to each other, we're not going to speak like that when we talk to the patients because they might not understand what we're talking about. So making sure that it's simple information that they can understand. And then we also can provide the information in writing. A lot of times we do print out, have handouts and things for them. Again, making sure that we're remaining vigilant about those side effects, because we don't want this person to end up having, like I said, stroke and heart attack because they're taking medicines to help them. Because there's so many help their, whatever their mental disorder is, because there's so many other medications out there that they can take. The doctor just has to find out which ones is best for them. And so those are the ones that they start off with. If the person isn't experiencing any rise in blood pressures and things like that, they just tend to stay with those. So non-compliance is an informed decision. So we want to make sure our client understands and knows all their questions are answered. So they have the right to refuse, but we want to make sure they make an informed decision about what they are refusing. Work with clients to find out and eliminate the factors that lead to non-compliance. If we're saying that, they have a therapy session, a talk session with or desensitization session, on Wednesdays. If Wednesday's not a good day for them, if it's a difference between them non-compliant, see, can we get it offered on a different day? Maybe a different provider. So informed consent, presenting clients with information about the benefits, the risk, and the side effects of those treatments. Enabling them to say, hey, yes, I want this treatment, or hey, I do not want this treatment. So the Patient Self-Determination Act states that clients have the right to accept or refuse care and cannot be pushed, coerced, or talked into following a certain course. Okay, any questions about those myths? Like I said, it's kind of like a review because we went over them. Okay. So remember, you all, these sessions are recorded. Anything that you need to step away from the camera for a few minutes or so, please do so, because we don't want them to count your time as not being present once they're reviewing the videos and they're seeing, other things are going on. So if you need to step away for a few minutes, please do so. All righty, we're almost there with all of our content. Almost there. How y'all feeling about the exam for next week? We're almost there. We're going to talk about our mental health assessment skills, and then we have one more topic. Then we would have covered everything. But like I said, once we come in next, Dr. Bugs is going to Cutler. We'll actually do that review on Sunday. And then when we come in on next week, we'll hit all the high points, and then we'll actually take the exam.
Will we have any content to cover like before the exam besides reviewing?
We will go back over everything again. It won't take this long. It'll be narrowed down. It won't be any new information.
Okay.
Yes, not any new information. Now, if you want to look at the PowerPoints without all the added stuff that I've added, they're there in your in your announcement sections. I just like adding all the little topics there. But yes, we will have covered all of the topics. And then so it will be like a true review, no new content, no surprises. Okay, so let's look at these. Share my screen. Okay. Those are our objectives. Okay, every psychological problem has physical effects, and each physical illness has psychological effects. The wise care provider is aware of both. Individuals entering the mental health care system undergo a comprehensive assessment. Clients are interviewed by several members. So make sure that that in itself can create some anxiety. So let the patient know, hey, I'm coming in and interviewing you. There will be 2 or 3 others. Some of the questions may be the same questions that I've asked. Just go ahead and let them know that. That's just part of our procedure. It's good to just let them know that. So the doctor for social work and the dietitian. We talked about why we might have to pull that dietitian in. The social worker identifies, they assess the client's family and work and social interaction. They identify all these other resources that we might not be aware of in the community. Okay. So we have the psychiatrist and the psychologist that explore emotional and cognitive intellectual functioning. So of course, as a nurse, we assess how the illness or disability affects the client's activities of daily living. You know, are they able to bathe themselves? Are they washing their clothes? Are they still going to work? Are they taking care of their children? Whatever those responsibilities are of daily living. Other care providers contribute information through their observations and interactions with the client. Let me just stop and see. I think there's a comment in the chat. What time on Sunday? I'll look back at it. Look back at the announcement. Don't let me forget to look back at it once we finish. So when the team and the client agree on treatment goals, a course of action is planned. Because remember, it's the patient that's receiving this care. So they have to, say, hey, yes, I want this, or I need some alternatives. In the event that they say they want some alternatives, we let them know what they are, and then hopefully we can come up with that plan and move forward. Plan may include medical treatments. It may include behavior or psychotherapies or other therapeutic actions. Treatment plans are developed especially for individual client, which we do that anyways. Care plans, they're individualized. Okay, so the purpose of the mental health treatment plan is their care plan. It guides us in how to implement interventions for this specific person. It's like the recipe of how to take care of me, that person, that patient. It serves as a means of communicating and coordinating client care because we want the client to see all of those people that was on that previous slide. We want them to see the psychologist. We want them to go to their therapists, the breakout sessions. We want them to see the nurse. We want them to be able to see everybody. So we have the DSM-5. It is a tool that's used to facilitate the diagnosis and guide clinical practice. So you all should have that book available for you in your Canvas shell. Clients are assessed and classified according to those 5 categories. This system helps providers gain more complete understanding of each person. Okay. Of course, we're doing our nursing process. We want to encourage the client to focus on, encourages us to focus on the client and develop appropriate, effective care measures that are specific to that person. What we do during each stage, we collect the data. Data is sorted in related areas and problems are identified. We start planning and then we start implementing. We start doing, implementing those interventions. And then we evaluate, has this done the patient any good? Or do we need to go back to the drawing board and come up with some more interventions for this patient? Or they may have worked or working. So clients are involved as partners in their care because they're the ones that's receiving the care. Caregivers can also help if the clients want them to be a part of it. Okay. The gathering and verifying communicating of information is relative to the client. We want to think about the whole client, all aspects, physical, intellectual, their social, cultural, and spiritual aspects. Think about all of that. Of course, we're collecting subjective and objective data. The experiences of pain, nausea, and anxiety cannot be measured by anyone other than the individual experiences. So if they're saying it, we still write it down. But then we also document the information that we have gathered, based on our observations. The psychiatric assessment tool focuses on obtaining data about the problems, coping behaviors, and resources of the patient. The risk factor assessment is required for clients who may pose a risk for violence toward themselves or others. So we do want to make sure, and the RN actually completes that, but we want to make sure that that is done. Okay. So success of any client interview rests on the caregiver's ability to listen objectively. We're not, we're asking questions and we're doing everything, but listening to the patient and making note of what they're doing. That's not a successful interview. Matter of fact, if we don't have time for them, we may need to clock out and go on home or exchange tasks for that day, because that patient is going to need your attention, and we need to be actively listening, because in the event that they give a certain response, we may need to ask a more focused question to gather more information. So we need to be paying attention to what they're saying verbally and what they are saying non-verbal, those non-verbal cues. Okay. Review of each body system and its functioning. Clients are questioned about the following: their general health care, the past illnesses, the past hospitalizations, current medications, past medications. We talked about that. The lifestyle and the activities of daily living are also assessed. What do you do, from day to day? Because not everybody, has the same routine. So, what are your day-to-day activities? Work? Are you retired? What is it that you do? And then if you do work, like, what are your hours? Because everybody hours are different. So a complete physical examination is preferred by the physician or nurse practitioner. We do have diagnostic studies. Blood will be drawn, so just go ahead and prep them for that. Okay, we're gonna need a urine specimen. We're gonna because remember, we need to rule out medical anyways. So they'll get that EKG to see, and that will establish their baseline, especially with that EKG, because we know that some of those medicines can cause arrhythmias in patients. So having that baseline ECG, we will know if there's a difference or a change as a result of that client taking that medicine. So this examination allows care providers to observe and describe a client's behaviors in an objective, non-judgmental way. Understanding each part of the examination enables care providers to plan and deliver most appropriate care. Okay. So this examination explores the following areas: general description, their emotional state. We're asking them how they're feeling, and also we are making note of, are they making eye contact? Are they guarded? Is their voice raised? Are they being aggressive? We're making note of all of that also. Even their speech. Is their speech clear? Or is it garbled? Is it word salad? Is it, there's different terms that we can use to describe the speech, but if the speech is not clear and coherent, describe it. It could be, like I say, a word salad. They just mentioning just random things that are not, reasonable. We want all findings to be documented. Okay, we want to consider their mood and their affect if we are documenting on their emotional state. Experience assessments explore the client's perceptions, which is the way that the client, he or she, experiences the world. So we're writing down whatever it is that they're saying. Okay. And then that helps us to determine the patient's sense of reality. So if they're saying that it feels like they're riding on a cloud or riding on a wave, that helps us determine, are their sense of reality at that moment. So thought content relates to what an individual is actually thinking. Clients may be experiencing delusions, hallucinations, amnesia. They may not even remember They can be making up stuff. So we just want to make sure that we're making note of all that they're saying, because then we're going to go and fact check or just compare, and we can tell whether or not, get a little bit more understanding of their mental status. Sensorium is a part of the consciousness that perceives, sorts, and combines information. People with a clear sensorium are oriented to time, place, and person. Okay. And that's a direct relation to their judgment and the things that they will actually, in their perception of things. So any questions about the examination that we do, that mental health examination? Are there any questions? Okay, I'm seeing heads go from left to right, so I take that as being no questions. Let me toggle back and answer your question about the exam review real quick, because we're almost there. Take a moment for it to pull up. Okay, let me just share here. So her info, was posted on the first. So I know in your class, because we have so much going on in this class, but go down to where it says pre-lecture exam review announcement. And then you have her login information for her Zoom. So it will occur Sunday, August 9th at 2:30 Eastern time. And like we said, this is her Zoom information right here, the meeting ID and the password. But again, if you're unable to attend, she will share the link. So make sure you're reviewing that. In addition to that, the classroom recordings. Let me see if there are any other questions. Oh, I think I got all of them answered. So let's look at this stress and coping, and that should take us on out here. Share my time here. Uh-oh, stop sharing. Stress and coping is a continual process that starts with an event that is experienced by the person, perceived through intact information, processing channels, and appraised for scope and meaning, assessed as neutral, manageable, or threatening within current capacity of coping skills, resources, and abilities, ending ideally in a positive outcome of homeostasis and feelings of well-being. So stress happens to everyone, but then for the most part, we're actually able to cope with it. And in the end, we have those positive outcomes and we feel okay about it. There's that continuum of stress though. Neutral becomes challenging, but still manageable. And then you have that part where it becomes not manageable. Okay. And of course, it will affect all the body systems. That stress. It may make your head hurt, stomach hurt. It can affect all the body systems and it affect people differently. Okay. We do have all different types of stress. The environment may cause stress. It's hot outside, storming, all those different things that we're experiencing can cause different levels of stress. So chronic stress produces negative outcomes. So if that stress is not relieved, if there isn't an answer, so to speak, if it becomes chronically, then it can negatively impact all of our body systems. It could lead to hypertension, weight gain, all different things like that. So we talked about the population is most at risk. It's going to be those infants and children because they solely rely on someone else, parent or guardian, providing for them. Okay. So those histories we're gathering in that information, we're going to look for clues. Can also be within the psychosocial component of the history. So be listening, be an active listener, listening to what they're actually saying and the things that they're not saying. That will guide us into asking those more focused questions. And sometimes we might have to change out the nurses asking the questions. If with things like the client is not receptive to us, and forthcoming with the information, it might that we need to, exchange patients. We need to have someone else to come in. And that is okay. Okay, so primary prevention, we talked about that exercising, preserving positive self-esteem, promoting effective coping and health and well-being strategies, maintain that good health and proper nutrition, going to see your doctor, I'm going to the dentist, making sure we're eating that balanced meal. Secondary, there are some screening tools, some surveys that could be asked either electronically or on paper, but we're asking those questions to detect or determine if there's some stress there that's not being relieved. Recommendations for screening in situations related to mental health that are linked to ineffective maladaptive coping, substance abuse, and depression. So we want to make sure that we're administering those screening tools that specifically ask about these things here. There are several different tools out there. So collaborative interventions geared toward reducing actual perceived threats, making sense out of, gaining a more reality understanding of what is really going on and how we can move forward. So we do have problem focused coping, emotion focused, and meaning focused. Okay, so common positive coping strategies, education, seeking out that social support. Sometimes they just want someone to listen. They don't want to answer. They just need somebody to listen, but that helps them cope with whatever's going on. Music therapy. And, this is not an exhaustive list. Maladaptive, those not so good coping strategies that will lead to a temporary relief. Smoking, overeating, how, I'm just going to eat this cake or eat this extra serving. That once you've eaten it, the issue is still there and we haven't worked through it. Okay, so those medications, we talked about the different medications that they might end up taking. So these are just some concepts that are related to what's going on with them. So we want to consider hypertension because over time, that chronic stress, it can make those body systems not function as they're supposed to. So a patient may experience any of these. What powerful tool would increase self-efficacy and control for a person who is stressed? So in the chat, put 1, 2, 3, or 4. Just put the number. I'll give you a minute to answer. What powerful tool will increase self-efficacy and control for a person who is stressed? So just put your number there. And then we'll check it here in a minute. Okay. Education regarding the situation. An alternative coping measure is a powerful tool. And someone mentioned that early on, way back we started tonight, to increase self-efficacy and control, providing that education. Because most of the time it's just that the person doesn't know and understand, not because they don't want to take care of themselves. Okay, so let me restart my timer here in the chat. Just put 1, 2, 3, or 4, and we'll check yourself in just a moment. I'll let you read this one. All right, let's see how did we do. 5 more seconds. Okay. Individuals who are very young may not have developed adequate coping strategies. Adolescents are still developing and at a high risk to choose ineffective coping strategies in times of stress. Older adults may have lost mobility and may have a reduced social structure for support in times of stress. So age is a key component. Okay, let me restart and in the chat, put 1, 2, 3, or 4. Five more seconds. Go back. All of the above. Remember, we said that it will affect all of the body systems, some more than others. So, stress can cause negative outcomes throughout many body systems, including the central nervous system, cardiovascular, the immune, musculoskeletal, GI, the skin, reproductive, on and on and on. Stress does not discriminate. It can affect all of them. Like I said, it depends on the person of whether or not, they're having GI issues. That's gonna vary between the person. But stress, person said, well, my face is broke out. I'm having this acne. It could be just a stress. Having stomach issues, keep having upset stomach. It just affects everyone differently, but nevertheless, it can affect all those body systems, all of them. Okay. So to lessen your stress, make sure that you have your ID. Make sure you have your 2 devices, your chargers. If you're going to use a dry erase board, make sure you already have that in place. Pick out your space that you're going to take the exam. Go ahead and get that set up. We're a week off, but still, next week will roll around so fast because you have so many other things that you're doing. And then be looking at your schedule to see what you can delete, rearrange so that you can spend the time with the content. We went through everything tonight. Next week when we come in, we'll do a shorter version of reviewing everything, and then we'll take the actual exam. So we say the rest of our minutes toward the end. You all be pushing through, which is good. We can take longer breaks in between, but you all push on through, and you step away when you need to and come on back. So we officially are finished. But I will stick around if anyone have any questions or concerns. We can go in the breakout room and talk if we need to.